Welcome back, Summer Session 1, Week 4. Today we're going to talk about upper GI disorders, and there'll be a second video which will discuss lower GI disorders. Objectives are to create a nursing care plan for one upper GI disorder, identify the differences between gastritis and esophagitis, and describe the diagnostic tests used to diagnose upper GI disorders. Esophageal disorders and stomach disorders are two separate categories that we're going to talk about. And we're going to talk about gastroesophageal reflux disease, or GERD, and hiatal hernias. And then for the stomach ulcers, we're going to talk about gastritis, peptic ulcers, and we're going to touch a little bit on the upper GI bleeds. So the pathology of GERD is most common, caused by a relaxation of the lower esophageal sphincter, and it's the GI system normally works on a high pressure system. Well, the pressure is changed to a lower pressure and causes a relaxation of the lower esophageal sphincter, which allows for regurgitation. Causes include foods and drugs that influence the function of the lower esophageal sphincter, smoking, alcohol, which weaken the lower esophageal sphincter, NG tubes, gastric distension, which causes excessive relaxation of the esophageal sphincter, and Heliobacter pylorus, which is H. pylorus, which is a bacterial infection, causes increased acid exposure, which leads to erosions and alterations. Clinical manifestation: heartburn, pyrosis, acid reflux, dysphagia, chronic cough, asthma attacks, laryngitis, and abdominal pain. And the asthma attacks are caused by the irritation of the bronchi, and chronic coughing could have influence on that. Complications are Barrett's epithelium, which is a colander-shaped epithelial tissue which line the esophagus as indicated by healing, and they can be pre-malignant cells which have an increased association with cancer. Esophageal structure also indicates healing but can lead to dysphagia. Diagnostic tests include esophageal endoscopes, and also the way it's diagnosed is by the clinical manifestations. And you can see pictures here. The red picture to the right is what GERD looks like with a scope, and the other picture shows exactly what the scope is and how it works. Treatments include medications such as magnesium salts, histamine blockers such as famotidine or rididine, proton pump inhibitors, which is omeprazole, and or protein kinetic drugs such as metoclopramide. Diet restrictions are to include or limit chocolate, caffeine, carbonated beverages, alcohol, fatty foods, especially fried, spicy and acidic foods such as orange juice or tomato juice. NCLEX question number 1. The client with GERD is prescribed famotidine. In order to provide effective teaching, the nurse must include which information about the drug action? I will post the answers and rationale on Wednesday to all the NCLEX questions. Hiatal hernia. There's two pathologies, sliding and rolling hernias. The picture shows, I think, a good example of each one. The sliding hernia is like an outpouching of the esophagus above the lower esophageal sphincter and above the diaphragmatic opening. And then the paraesophageal or rolling hernia is kind of an actual pouching of the stomach up through the diaphragmatic opening. Clinical manifestations for the sliding hernia: heartburn, regurgitation, chest pain, dysphagia, and belching. With the rolling hernia, feeling of fullness, breathlessness, feeling of suffocation, chest pain, and the recumbent position makes it feel better. So it's important to make a good assessment of the chest pain because that also could indicate heart issues, right? So you need to be careful with that. The feeling of fullness and the breathlessness is due to the pressure of the stomach above the diaphragmatic opening. Complications include volvulus or obstructions and strangulations. A picture here is of the volvulus, which is a twisting. Obstruction would be where it's either partial or complete, and a strangulation would be where actually the blood supply is cut off to the stomach and cause necrosis. Diagnostic tests include barium swallow with fluoroscopy or esophagastroduodenoscope or an EGD. And the picture shows a hiatal hernia there. It looks like it's a rolling or a sliding hernia. Treatment includes non-surgical, which are the medications, the antacids, the protein pump inhibitors, the H2 receptor blockers, or the prokinetic drugs, as well as diet we've talked about, and lifestyle changes, losing weight. Surgical treatments are Nissen fundoplication, which is a reinforcement of the esophagus to cause strength so it doesn't outpouch. And question number 2, which of the following assessments is essential for the nurse to make when caring for a client who has just had an EGD? Gastritis. There is acute, which is an sudden onset and typically short-lived. Chronic, which can be ongoing with mild to no symptoms. Erosive gastritis, which can cause the stomach lining to wear away, causing erosions, which could be shallow breaks in the stomach lining, or ulcers, which could be deep sores in the stomach lining. Non-erosive gastritis causes inflammation in the stomach lining. However, erosions of ulcers may not accompany non-erosive gastritis. Common causes are that H. pylori infection, stomach lining damage, and the H. pyloric infection is particularly in developing countries. It is an oral fecal route contamination transmitted typically in childhood or by contaminated scopes. Sometimes people with this infection never have symptoms. Adults are more likely to show symptoms when symptoms do occur. Reactive gastritis may also be called reactive gastropathy when it's caused little or no inflammation. The cause of reactive gastritis may include nonsteroidal, anti-inflammatory drugs, and other types of over-the-counter medications. Aspirin and ibuprofen are the common nonsteroidals. Drinking alcohol, using cocaine, exposure to radiation or having radiation treatments. Reflux of bile from the small intestines into the stomach. The bile reflux may occur in people who have had part of their stomach removed. A reactive stress caused by traumatic injuries, critical illness, severe burns, or major surgeries. This is a type of reactive gastritis, and it's called the stress gastritis. An autoimmune response gastritis is the immune system attacks healthy cells in the stomach lining. The immune system normally protects people from infection by identifying and destroying bacteria, viruses, or other potential harmful foreign substances. Autoimmune gastritis is chronic and typically non-erosive. Clinical manifestations are as listed. It's important to make sure that you check for blood in the emesis, and that would be indicated by a coffee ground color emesis. Gastric hemorrhage can be fatal. And then chronic gastritis, the vague report of epigastric pain relieved by food is the main difference between the two. Nausea, vomiting, again, intolerance to spicy and fatty foods, pernicious anemia. Complications could include peptic ulcers, and the picture shows peptic ulcers there, anemia, B12 deficiency, pernicious anemia, and malignant or non-malignant growths. Diagnostic tests are the EGD with biopsy, urea breath test, which measures the urase that's released by the H. pylori, blood tests, and the ELSA test, which is an enzyme-linked immune sorbent esterase. And of course, hemoglobin and hematocrit to identify any blood loss and to see the extent of it. Treatment includes non-surgical to treat the acute pain, correct fluid and electrolyte imbalances, and blood transfusions as needed, and surgical partial gastrectomy, pyloroplasty, or vagotomy. And this picture shows a partial gastrectomy, the differences being where the stomach is connected. Peptic ulcers. The peptic ulcers are created by the H. pylori bacterium, which is developed usually in the antrum of the stomach, and it's a break in the mucosal lining. Then the hydrochloric acid causes epithelial damage. It causes a backflow of acid because of a dysfunction of the pyloric sphincter, causing bile salts to migrate to the antrum of the stomach. Most duodenal ulcers occur in the duodenum. They are deep, sharp lesions that penetrate through the muscular layer of the lining. They have a high gastric acid content, which means a low pH. Protein-rich meals, calcium, vagus excitation stimulates acid production, and these people have a confirmed H. pylorus infection. Stress ulcers can be caused by major medical illness, trauma, such as burns, sepsis, or head injuries. Epigastric manifestations, epigastric pain for the gastric and the duodenal ulcers, dyspepsia, and nausea and vomiting. And the picture shows the different regions where you would indicate or see the pain as far as if it was gastric or duodenal. Complications include hemorrhage, perforation, and pyloric obstruction. This shows a picture of hemorrhage, and the diagnostic tests that can be done are the EGD, the upper GI series with barium, and laboratory tests. Here's another picture of an EGD being done. And treatments with medications are fourfold. They're aimed at healing the ulcers, the treatment of infections and the underlying cause, preventing reoccurrence, and pain relief. And last, we're going to talk about a GI bleed, which is non-surgical management. Could be an NG tube and lavage of room temperature saline or water. Endoscopic therapy, which could be a clipping of the bleed, or electrocautery use to coagulate. Interventional radiology procedures would be the clippings. Surgical management, again, are the subtotal gastrectomy, pyloroplasty, or vagotomy. And the picture shows the vagus nerve and where the vagotomy cut would be. It's important that you can identify the difference between an upper GI bleed and a lower GI bleed. These can be life-threatening and can lead to hypovolemic shock and massive hemorrhage and death. The upper GI bleed is characteristic of the coffee ground looking emesis and dark tarry stools with a positive hemoculture or stool sample. Differentiating between the two, like I said, is important, and it's as easy as the identification of the color of the stool. Dark tarry stool indicates an upper bleed because it has to go through the system. Come back next week. Come back and see the next for lower GI bleed and your assignment. Thanks. Have a good day.